Hope everybody had a great EMS week. Hope you enjoyed your pizza parties. And if you are a night shifter, I hope you enjoyed the leftover of everybody else's gifts. No, I'm just kidding. But happy EMS week. Thank you for all that you do. Thank you for the calls, the care, the comfort that you give in the moments of chaos and absolute ridiculousness and the times that you've bitten your tongue because you didn't say what was on your brain. Thank you. No, for real, EMS week. I feel like it doesn't get enough credit that it deserves. I understand that like there are budgets and there are things in line of how much we can actually do. And if you work at the agency I work at, you understand that there is a lot that is done, a lot that is done for the employees, and it matters when you have management that actually cares. But I've also worked in services where that was not the case, and EMS week is just another reminder of why am I doing this. I also though like if I just get a thank you from one of the higher ups, that's enough for me. I don't know. I feel like EMS week is such a thing that we don't expect much, but also we expect at least something. I don't know. Um, but EMS week, happy EMS week. Thank you for what you do. So, and part of being an ambulance driver, and part of being an EMT, a paramedic, whatever level you are, an advanced EMT, we have to have a differential diagnosis. Any patient you have to have at least some working idea of what is going on with the patient. This was a very hard segue, and I am sorry for that. Anyways, um, but you have to have some idea of what's going on. So, like, you can follow protocols or you can follow some kind of direction that you're heading of how you're going to treat this patient. Obviously, we all know that. However, there will be times, and I recently have encountered one of these, where you don't know what is wrong with the patient. You don't know what the differential is. You have a ballpark, and that is what you're working in. And those are hard calls. The calls where it started off, so this is where I start off with this episode idea. I forgot what was going on with the patient. I forgot what we were trying to treat, what we were trying to figure out. I think it was a seizure, not 100% sure. Sounded like a seizure, kind of if it looks like a duck, looks walks like a duck, quacks, whatever. Whatever that phrase is, then it's a duck. It was one of those. Um, but after the call, I looked at the student that was with us and I said, "So what do you think is going on with the patient?" And he looked at me. It was like, and I said, "Do you not know?" And he was like, "No, I don't know." I said, "Yeah, me either." So we just treated what we thought had, and I think that's okay. I think it's okay to number one be honest with yourself and your student and say when you don't know, but also I think it's okay that you have an idea and I understand this is what a differential is. I'm not trying to mansplain a differential diagnosis, but like even if you can't put a finger exactly what it is, you may not be able to differentiate what it is in the field at all. My theology and the whole point of this episode is that you have what you have in front of you and you need to treat what you have in front of you, whether you can put a name to what is going on or not. And this, I feel like, ranges from our stable patients where maybe it is just the cancer flaring up again, or maybe it's something else. Maybe it is just a stomach ache, or maybe it's something else. Maybe it is just the flu, or they're actually in compensated shock from their pneumonia they've had for the past 2 weeks and we didn't know it. Whatever it is, you have some form of an idea of what you're looking at treating. You have some form of an idea of the general ballpark. And we range from these small ones to like one time I had a lady that we got there and it came out as like she fell and injured her arm. So we get to her and the firefighters are telling us that something's wrong, something like that. And like we're asking this lady where she's hurting and she's telling us her arm when we sit her up because she'd been on the ground. And when we sit her up, that's when we noticed the facial drooping. That's when we noticed that things were not okay and things were going wrong. And they continued to go wrong the whole time. Could I have diagnosed from this woman that she had a brainstem herniation? No. There's no way. Maybe you have mastered having a CT in the back of your head and you can have x-ray vision and you can differentiate that. Congratulations. I am not up to your speed. I don't know how to call a brainstem herniation in the field. But what I can do is look at this woman and say, oh no, there is either a stroke or a bleed of some sorts like that. And that's what we're going to treat. And that's how every time that something else would arise, we just treated what we had in front of us. And I understand there are ways to figure out if it's a left-sided brain bleed or a right-sided brain bleed, and you can tell the type of stroke it is based on specific symptoms. I get that, but also maybe this makes me a lazy paramedic. I don't care about that. Right in front of me, I don't care if it's left side or right side brain herniation and bleeding and hemorrhaging. I don't care. All I care is that things are going on that are not supposed to be going on, and I have to treat what's in front of me. And in the meantime, and what I feel like needs to be a bigger emphasis, rather than where the brain is bleeding in the whatever, should I know an idea? Yes. But do I need to be able to diagnose right then in the field? No. What needs to happen is I need to get a better history. I need to do a better assessment. I need to do a better stroke scale, not to figure out if it's the left side or the right side, but to figure out how much of this person's, whatever the words I'm looking for are, how much of their brain is still perfusing, how much of their brain is actually still getting oxygenation. Is the blood sugar enough that the brain is going to have the sugar to work on to continue to perfuse in the right areas? Things like that. What is the blood pressure? I feel like it's another important one. Anyways, this isn't a super long episode. But I also feel like it helps us when things are going south and we can't put a name to what is going on with the patient. And maybe they were walkie-talkie in front of us, and now they're decompensating and we have no clue what's going on. We're treating what we have in front of us. I feel like it also helps us at the end of the call to be able to walk away with a clear conscience and knowing that maybe we couldn't diagnose a PE in the field immediately right in front of us, staring at us, even if all the little indicators are there, even if we can't diagnose that, knowing that we're still treating what's in front of us and we're doing everything we can, because that's what I feel like is the hardest part about this job is not things we see, which is hard, but it's for me at least, it's am I doing everything that I can? Because when you think about it, even though we have a lot of medications, we have skills we can perform, we have interventions, we have, little shortcuts we've learned along the way. We have things to literally save lives, and that's in our tool belt, that's our job, etc. Happy EMS week. Anyways, I still feel like, where was I going with this? Oh, even though we have all of this, we're still kind of limited in what we actually can and can't do. We don't have the ability, and if you do in your system, congratulations, great. We can't do blood tests in the back of the ambulance. We don't have CTs. We don't have x-rays. We don't have MRIs. We don't have all of the other tests that the hospital does. We can't run scans. We can't give actual diagnoses. And so even with these differentials that you should have an idea of what's going on with the patient, even if you can't name it, we're still limited. So even if what I feel like a lot of people do, maybe you get the differential wrong. Maybe it's not a COPD exacerbation, but it's actually pneumonia, but you gave an albuterol and Doneb. I think that's fine. You heard wheezing. You fixed the wheezing. Congratulations. Does this give an excuse to just be lazy and make shortcuts and do things that could harm the patient if you do the wrong thing? No, there's no excuse for that. You should still have a good understanding of what's going on to make your complete differential and back up what you're thinking. It's not a matter of just coming to a differential. It's not a matter of just coming to your diagnosis of what's going on, but it's also a matter of, can you back it up? There's so much that we can do with such a limited amount of information in front of us. And that's, hopefully you have a patient that's able to talk at all and you're not just relying on bystanders for information. Happy EMS week. Anyways, not a long episode. I just feel like it's important to remember that, like, even if you don't have all the answers in front of you, even if outside of differentials, the moments when you're looking at yourself and you're thinking, man, I really hope I'm doing the right thing. Treating what's in front of you with what you have is all you can do. And in the ending note, remember to take care of yourself. I don't know. There's a lot I don't know, and there's a lot that I do know, but I also know that, like, we beat ourselves up way too much. And this is me probably recording an episode for myself more than anybody else. I may not be able to tell you exactly a perfect doctor explanation for what's going on with the patient, but I have an idea. I have a differential, at least, that I'm working up on. I'm crossing T's and dotting I's, fixing what's in front of me. In worst case, you stabilize the patient to get them to the ER so they can make the differential like they can. Do we have a lot of power and ability? Yes. Do we have a lot of freedom and responsibility? Yes. And I feel like that strengthens us more than it weakens us. And the biggest hurdle we have is our own selves. So, a little all over the place with this one. Just kind of, I've had this idea of ruminating in my brain for the past couple of weeks. Just wanted to get it out. That's all I have. If you have any questions, comments, concerns, drop a comment, send a DM, do what you got to do. Thank you for all that you do. Happy EMS week, and stay safe out there. Stay safe out there. In honor of EMS week, I'm going to go get a snack, probably an Uncrustable. And as I end every single episode, so with that.
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.